all my friends were asking what I was going to talk about anesthesia in a cardiology conference where cutting-edge technology and everything is being discussed. So I'll try to keep you entertained because I know there are quite a few interesting things coming up in the next few minutes. So I would like to rephrase the title of this talk as the role of cardiac anesthetist in CHIP, because I am somebody who believes that a cardiac anesthesiologist is somebody different from a routine anesthesiologist. I'll come to that later as we go along the talk. That's where I work. That is Cleveland Clinic, Abu Dhabi. It's situated on a man-made island. It's the largest referral center for cardiology and cardiothoracic surgery in the whole of United Arab Emirates. We are an advanced center offering very high-end complex PCI. We've crossed about 250 towers, about 100 mitral clips, LA appendage occlusion. We do all kinds of high-end cardiology work. And all referrals from across the whole country come over as a quaternary center to Cleveland Clinic. Start off with a case. It's a 63-year-old man who came to us with a history of coronary artery disease with a LCX stenting 7 months before, and diabetes, hypertension, end-stage renal failure on hemodialysis. Presented to outside hospital with an end-STEMI and a newly developed left bundle branch block. Echoes showed an EF of 25%, moderately dilated LV with severe global and apical echinacea. Cath showed in the outside hospital subtotal restenosis of the ostial LCX stent, left main with moderate to severe stenosis and a patent LAD stent. RC also showed moderate diffuse disease. So he was transferred to us with a small dose of norepinephrine infusion for hypotension. So the case was discussed in our morning heart team meeting, and a decision was made to go for for a complex PCI because of the comorbid conditions. And we took him to the cath lab as an elective case. So initially, we decided to do under GA because the patient was very anxious and we are not sure if he would stay quiet on the table. So we shot the iliac arteries, as is our practice before impella insertion. We decided to do under impella support. On the right side, we confirmed the position of the impella before proceeding with the PCI. So it is the impella CP that we placed through a right femoral axis. So I had the TE and I was able to assist the cardiologist in placing the accurately. Of course, fluoro is what is used very often to place the impella, but I was able to supplement that with my own TE. So you can see the LAO caudal view on the left side and the wire in the LAD, and on the right side you can see the impella in place. And we did a complex bifurcation left main LAD LCX intervention. And throughout the procedure there was hemodynamic stability. And there was a final kissing inflation, and the results can be seen with good flow in the right side frame in the right caudal view. The course, the patient remained hemodynamically stable during the case. Impella was removed after 1 hour. He was discharged home 4 days later, and 1 year later, he remains asymptomatic. That was an elective case that I presented to you. The next case was a case which came last weekend when I was on call in the middle of the night. A 30-year-old male with an out-of-hospital cardiac arrest. Initial rhythm was PEA. Later came to our hospital with ongoing resuscitation, and he went to VFVT. 20 minutes of CPR outside the hospital and 15 minutes in the hospital. He was rushed to the cath lab with ongoing Lucas chest compression. That's what we do when we have cardiac arrest coming to the cath lab. And we decided to go for an emergency ECMO-assisted PCI. So that is, the reason I put this clip on is that anytime a cardiogenic shock comes into a cath lab as an emergency, I straight away, when I get called in, everybody knows that I go straight away and put a cardiac central line and a PA catheter. We do not do any of these cases without a PA catheter. And the PA catheter in this case, I tried to float after the ECMO was coming, so I had difficulty, and the cardiologist guided me with the fluoro. So we work very closely, the anesthesiologist, the head end, and the cardio, and they even paused the procedure to let me float the PA catheter. We float the PA catheter, get numbers for almost all cases of emergency PCI coming with cardiogenic shock. Now, that was the PCA went ahead. You can see the RCA shot, and a stent was placed in the distal RCA PLV, and a second stent was placed in the proximal RCA with good result. The patient is still in the ICU. I, in fact, checked today. He's waking up slowly, but there is a lot of cerebral irritation, possibly significant neurological damage. But the revascularization went ahead with ECMO support uneventfully. The other thing I would like to point out is you can see the ECMO venous cannula coming up from below on the right-hand side, on the left side of the frame. Now, what exactly is the role of cardiothoracic anesthesiologist in a complex PC or a chip procedure? It's a complex environment for us because we are not used to the space we have normally in an operating room at the head end of the table. The image, we literally have to dance around the fluoro tube, and we have a long circuit. The machine is stationed well away from the fluoro. But what we bring onto the cath lab room is an added layer of safety. Why do I say that? Whenever I'm involved with a complex procedure, I insist on in the earlier part of the day. And as we mentioned in the morning today, I insist that there's a second cardiologist to back up or even scrub with the first cardiologist. Of course, I have the liberty of saying that as the head of the Department of Cardiothoracic Anesthesiology, people listen to me, but I encourage my team as a whole to go along on these lines. Do these complex procedures not late in the afternoon. Do it with a second cardiologist available, and make a plan before we do the sign-in. So I always insist on a meticulous sign-in with the WHO checklist. And this includes availability of the necessary pressors and inotropes within the cath lab, not in the pharmacy, not on the way. Availability of blood, cross-match blood should be available on the floor of the cath lab, ready to be used, and not again in the blood bank. I make sure at sign-in, I turn around to the nursing staff and the cardiologist and ask if you have all the available equipment. That means the catheters, do you have an echo machine in case of a crash or a tamponade? Do you have a backup CPB machine and perfusion is available? And availability of any other possible teams that might be required. So that explains why I do not like to do it at 5 o'clock or 6 o'clock in the evening when people have gone home. Preferably, complex chip cases are done in the earlier part of the day. And we also take on the responsibility of anticoagulation and monitoring. So the good thing about this is the cardiologist is completely free to focus on the challenging work he has on his hands without bothering about the anticoagulation, without bothering about the hemodynamics. We do serial blood gases and take care of the patient, leaving you completely free to focus on the job you have. Types of anesthesia. My dictum is that it's not the type of anesthesia that matters, it's the knowledge and the skills of the anesthesiologist. So elective cases we very often do under sedation. We use propofol and a target control infusion or a fentanyl boluses together that. Or in sick cases of bad LVs, we use ketamine. Ketamine doesn't depress the myocardial function. And we give a little bit of midazolam along with that because it avoids the confusion and delirium they have when they emerge. I always prefer to have my own radial arterial line and not a line slaved from the sheath because the sheath can get damaged at different stages of the procedure. A CVP catheter and a PA catheter depending on LV function. If the LV function is bad, and what do you mean by that? Less than 40% or less than 35%, we have a discussion at sign-in and decide whether the patient needs a PA catheter. Now, we use a lot of PA catheters in our place, and to be frank, inserting a PA catheter comes as naturally to us as an arterial line. And the whole team is tailored to is experienced with using the PA catheters, be it in the ICU or in the cath lab. Emergency chip, always we do under GA. They come intubated from the emergency department. We have a CVP catheter, a PA catheter, and most of the time TE as well. So positioning, this is something a very important message I want to send across. If you have elective PCI, somebody with pulmonary edema or reduced LV function, supporting them a little bit head up with something called an Oxford pillow. This is what we use in our cath lab. It's very useful. It improves the hemodynamics. The respiratory efforts are much better when you support them a little bit head up without compromising on the access in the femoral region. High flow nasal cannula. This is again something which I would encourage all units doing chip to look at. High flow nasal cannula is oxygen being delivered at 30 to 60 liters per minute. It's warmed, it's humidified, and it gives a consistent FiO2. So every unit doing a chip should have this specifically for obese patients, those with obstructive sleep apnea, the hypoxic patients, and those with COPD. It gives a consistent FiO2, unlike the face mask or the nasal cannula, and it's worth investing it in, and we have used it very successfully. The other good thing about this is it gives a PEEP of about 3 centimeters of water. So PEEP improves the oxygenation, and also the anatomical dead space is removed. So CO2 elimination or the CO2 levels also are much better, and it's much more tolerable than CPAP or BiPAP. PA catheter. Now comes the discussion. In our monitoring screen looks like this. If I am in the operating room, my screen looks like this. We have arterial lines, PA catheter, and multiple temperatures. And we have the facility to do bolus injection of cardiac output. Now the big question is to SWAN or not. This is a trial which came in JACC in July 2021, management and outcome of cardiogenic shock in cardiac ICUs. with shock teams versus no shock teams. They surveyed 24 ICUs, cardiac ICUs in North America, and they looked at it, and only 44% of the units had shock teams. The interesting finding was that those centers which had shock teams, 60% of the cardiogenic shock patients received PA catheter, whereas those centers which did not have shock teams received only 49% of the cardiogenic shock patients received PA catheter. And the interesting finding, if you look at the top part of the screen, is that all the patients who had pulmonary artery catheters, mortality was less, whether it was cardiogenic shock from acute MI or non-MI. Whatever be the cause of cardiogenic shock, outcome was better when you use PA catheter. And this has been shown in multiple papers, and the paper concludes that increased pulmonary artery catheter led to early institution of mechanical circulatory device, and preferably the PA catheter was inserted prior to the initiation of Impella or ECMO. And PSC is a valuable tool to assess the type of shock, and with more use of PA catheter, the staff and everybody in the unit gets more trained to or familiarity with it. Multiple papers again, the middle paper again showed that complete profile with a PA catheter improved outcomes in all stages of shock, all the stages of SCAI shock, whether it is C, D, or E. And this is the monitor, the continuous cardiac output monitoring I use. I use it in liver transplant and all the sick cardiogenic shock patients. That comes from Edwards. It gives mixed venous oxygen saturation, RV ejection fraction, SVRI, cardiac output, and it's a beautiful piece of kit. What other skills do we bring to the cardiac cath lab? We have transesophageal echo skills. You can assess the LV function. You can diagnose an ongoing tamponade with continuous TE rather than a transthoracic. We bring cardiopulmonary resuscitation skills, high quality CPR, administer the appropriate drugs in a timely manner while the cardiologist is proceeding with the PCI, and decision making in case the CPR is futile, whether to abandon the CPR or not. You have a friend in the room to discuss and decide on. Other contributions, I help the cardiologist place an antegrade cannula in the leg with a micropuncture kit, and whenever there is an arterial cannula in the leg, I insist on monitoring the nerves in the leg, which is what we use for oxygenation in the legs, if in case there is no antegrade cannula. That's continued we continue that monitoring in the ICU as well. So in conclusion, CHIP is not a lesion. I mean, I added the sentence after this morning. CHIP is not a lesion, rather it's a whole patient, and planning and execution is a team sport. No longer, I had the images of a cardiologist being a person bending down and working in isolation in the cath lab. That has changed. It's become a team of people surrounding him, supporting him. And a cardiothoracic anesthetist is an ally for the interventional cardiologist during complex PCI. And as PCIs get more complex and patients get sicker, there is more the need for a trained cardiothoracic anesthetist. Thank you.
Thank you.
We don't get to do much crosswords. There was an image that cardiac anesthetists sit and do crosswords. We don't get any time for that these days.
Arun, thank you for a nice presentation. I just have one question. I think that though PA catheter has been used traditionally by anesthetists, there's no randomized trial showing the PA catheter insertion improves. Most of the data which you showed, in fact we reviewed this in our club, showed that the reason why the PA catheters seemed to show better outcomes was they were in shock teams groups. Those teams were more aggressive. They put the MCS earlier than non-shock teams. And maybe that was possibly the bias of getting the outcomes. And I think there was a European Heart Journal article which looked at this very carefully, the meta-analysis of all. And it said, yes, it helps, but the data is sparse and not randomized. I don't know whether I'm saying the right thing.
If you look at very beautiful lecture.
Thank you very much.
And you know, this PA catheter stigma we got from previous trial where the PA catheter does cause increases the mortality because of sepsis and other things, arrhythmias, etc. Definitely PA catheter is important. Now my question to you, do you think the pressure-volume relationship of the left ventricle, pressure-volume relationship of the left atrium is going to translate in a better understanding of the shock? Because you have given a very advanced lecture on the usage of MCAs and anesthesia, etc. Though these are theoretical consideration, but since you are an anesthetist, you understand pressure-volume relationship better than us. Do you think there is scope for pressure-volume relationship carved by a special catheter on the LA side? It is difficult, you have to do the puncture, then you do that. But LV side, you can do it.
Yeah, definitely. There is scope for that. Basically, the reason I think the PA catheter went out of use was that it was beginning to get more complex for the people manning the ICU and using these catheters. See, most of the studies which threw the PA catheter out came from general ICU and in sepsis. I think my take on this is that this was all done by people. A beautiful piece of kit was taken away from you guys by the general intensivists because they found it hard to understand. The general ICU training, those people found it hard to understand. So talk about pressure volume loops. It'll be very difficult to educate people dealing with it, whether in the general anesthetists or the ICU people. Very useful without doubt, but to translate that into practice will be very difficult. That's what.
Sir, I got one question. So how will you decide the cannulation strategies for high-risk PCI when you plan for an emergency or an elective ECMO? How is the sites shared?
So normally, I mean, in the case I mentioned, they use one side access with the impeller going on the right side. And if it's an ECMO, usually we go for femoral, I mean, it's always peripheral ECMO.
Venous on the right side.
We on the right side, and they say right side is, they prefer. The axis is better on the right side. So right side, they go for the ECMO, left side they use for the PCI axis. And if it's an open chest or something, we go for central cannulation, of course.
Okay, thank you, Arun, for a nice lecture.